Good afternoon to all. So today I'm presenting a case on unique case on persistent IOP rise following YAG capsulotomy. So as we know, YAG laser is used to perform posterior capsulotomy, and it is a very common procedure. But the most common complication also we know is mild and transient increase in IOP, and other complications which can be they are retinal detachment and cystoid macular edema. So here I present a case of a 54-year-old female who presented with diminution of vision and pain in left eye, which was associated with vomiting. There was no history of glaucoma. The relevant history was that YAG cap was performed 5 days ago elsewhere, following which she developed pain and vomiting. This was the presentation. The vision was 6 by 24 and the IOP was 52 mm mercury. We can see there is circumciliary congestion, the AC is shallow, there is stromal edema, and the pupil is mid-dilated. So we took her up for B scan, and upon B scan we saw the vitreous was clear and there was no aqueous pockets. And on anterior segment OCT we found the AC was shallow, which was due to the anterior displacement of lens iris diaphragm. She was managed with the IV injection of 20% mannitol, and she was given all the topical anti-glaucoma medication and also topical atropine 1%. But after 3 days, the IOP was still high, which was 50 mm of mercury. The presentation was still more or less the same, and the pupil was slightly more dilated than before. So without wasting any time, we took her up for vitrectomy, and post-vitrectomy, the vision came back to 6.6, the AC got deep, and the IOP was 18 mm mercury, which was normal. So this was a case of malignant glaucoma, but the unique thing here is that YAG capsulotomy is a cause of this malignant glaucoma and not the treatment. So according to AAO, we can have such rare causes such as YAG capsulotomy. And also, this is different from the published literature because the YAG capsulotomy is a cause and not the management. The vitreous was clear, there was no aqueous pocket seen, and obviously the surgical management was necessary to avoid further damage as a lot of time has been passed from the complaint. Thank you.
Aastha, how did you manage this case? I mean, to get a malignant glaucoma after YAG capsulotomy, even though rare, but it is a documented one of the complication. So how did you manage? Initially, when you managed medically, atropine you started.
Initially, yes.
What was the frequency of atropine?
What was the?
Frequency of atropine. How frequently you told him to put?
So it was given TDS in ointment form.
Pardon?
TDS, 3 times
TDS,
a day.
yeah. So main thing is atropine has to be given at least 4 times a day, and steroids 4 times a day is enough.
Yes.
Wait for at least 4-5 days.
Yes.
Definitive management, so your IOP was not controlled. So surgically what you did?
Vitrectomy, pars plana vitrectomy.
Yeah, so when you only pars plana vitrectomy, will it suffice for the malignant glaucoma or something else has to be done?
Peripheral hysterectomy?
No. So basically, you do a vitrectomy. Initially, your IOP will get controlled, but patient will get frequent attacks of malignant glaucoma. So to control that, we do have to do a YAG, surgical laser hyalidectomy with vitrectomy and zonulectomy. So you have to create one chamber from iris, zonule, anterior hyaloid, and vitreous. Then the frequency of repeated attacks will reduce. Fine. So it's a good case, well documented, very nicely managed.